Rheumatoid arthritis, you'll find it in your book on page 683. And like I said in the last presentation, a lot of lay people confuse osteoarthritis and rheumatoid arthritis. And there's a great table, 17.5, comparing the two, the age of onset, the gradual onset for osteoarthritis, sudden onset in rheumatoid, incidence, uh, gender, OA is more common in men, etiology, manifestations, signs and symptoms, etc. It's worth taking a look at that. It's on page 683, where the rheumatoid arthritis starts. Now, rheumatoid arthritis is a part of the rheumatic disorders, really the autoimmune disorders, and should be kind of lumped together with lupus and scleroderma, polymyositis, dermatomyositis, things that we've already talked about. It's a connective tissue disease that's autoimmune. Um, Now, primarily the target for rheumatoid arthritis, and the reason that it's here with the joint stuff, is that it's an autoimmune attack on the synovial membranes of the joints. But it can happen anywhere. Um, it's it's a systemic disease because it's autoimmune, so it'll affect more than just the musculoskeletal system. Uh, a lot of people end up with heart problems, especially valvular problems, pulmonary issues, GI issues. There's all kinds of other potential manifestations. Eye lesions are fairly common. Now, it's a fairly widespread demographic. It's kind of about 1% of the population seems to have it. So it's not unknown. Most of us know somebody who is struck down with it. Uh, it's one of these things that women get it 3 times as often as men, 3-to-1 ratio women to men. Uh, and it's usually between ages of 20 and 50. There's kind of a joke that once you reach menopause, you're kind of out of the danger. So it's probably got something to do with hormones. That's part of the etiological factor. We do see it in kids. It tends to have its own name. It's called idiopathic juvenile rheumatoid arthritis when you see it in kids. But uh, but one of the two risk factors, main risk factors, are being female and age, both of which you can't do anything about. Uh, so it's not really lifestyle uh, things. Now, your immune system attacks the synovial membranes. It's what causes it. Nobody really knows. Often there's some sort of a trigger mechanism, so we don't know very much about the exact cause. But what you get is a massive infiltration of immune cells, T lymphocytes, B lymphocytes, uh, and their products, antibodies, histamine, and the other inflammatory chemicals, all invade the joint, and the synovial membrane gets attacked. It ends up swelling and getting inflamed, and it ends up getting kind of a chronic inflammation. Um, and we'll talk a little bit more about it in a second. But what happens in the later stages, that granulous tissue starts to form at the site of the membrane, because it becomes histologically changed due to the chronic inflammation and the chronic attack on it, and we call that a pannus. So pannus formation, when you see a pannus in the joint, that's really pathognomonic of rheumatoid arthritis, of RA. Now, these inflammatory chemicals that are being released by the inflammation in the synovial membrane really affect the synovial fluid, uh, the fluid accumulates there because part of what the synovial membrane does is not only does it make synovial fluid, but it takes away the old synovial fluid, so it cycles it, and inflammation causes more fluid to be produced and less to be reabsorbed, so the fluid accumulates, and in that fluid are inflammatory chemicals that start to erode and cause inflammation in the chondrocytes in the cartilage, and so what happens is that the joint gets pushed open, it gets deformed, and the cartilage ends up being damaged by it. And so in the later stages, you start to get these deformations. And so, like this, in this radiograph, you can see that the metacarpal phalangeal joints are pushed way over, and the fingers are all ulnar deviated. And this is a real sign of rheumatoid arthritis. When you see somebody that has the four fingers ulnar deviated at the metacarpal phalangeal joint, it's rheumatoid arthritis almost for sure. Now, you can also see in this picture that there is kind of almost like this glowy whiteness to the where the articular cartilage is of the proximal phalange, and that's really the bone reacting to the inflammation. That's sclerotic changes due to the inflammatory things that are going on in the bone. There's also a little bit happening here in the wrist, especially kind of about the trapezium and the trapezoid. You can see the whiteness there. That's a sign of inflammation on this person's left hand. Um, so so this pannus formation, it's a destructive granulation tissue, and and really it does a couple of things. It stops the synovium from lubricating the joint or providing nutrients to the joint, and it it causes this erosion of the cartilage and subsequently the bone underneath the cartilage, so the subchondral bone uh, can get really badly eroded. Oftentimes, this will spread and start to attack the ligaments, and so joints become really unstable. It's uh, the it's marked by flares and remissions. It kind of follows activity in the immune system. Um, the people know it's coming. They feel like shit. They get malaise, and then they get sharp joint pain later. The joints are hot, painful, stiff. Um, Oftentimes, you get some improvement with some gentle movement. Some people say that heat helps it. Um, Paraffin baths and that seem to be helpful. It's systemic, so it is bilateral. It doesn't necessarily mean it's symmetrical, but it is bilateral. One of the things about OA is it doesn't tend to be bilateral. It tends to be in the joints that are directly mechanically affected. This being systemic, it happens, it's polyarthritic. It happens in a number of different joints on both sides of the body. Um, you can end up with these nodules. It affects the eyes a lot. It can affect the skin, the lungs, the heart valves. It causes vasculitis, which can lead to Raynaud's, and so if you look at these complications, they look a lot like scleroderma, and that's because it's very similar to scleroderma. You get these problems, really dislocations. the the extra fluid will push the joints right apart, and and especially in the metacarpal phalangeal joints. One of the big problems and one of the scary things with RA, and something to be careful of, is there's atlantoaxial issues. It can actually kind of erode away at the transverse ligament, and the and the dens can push against the spinal cord, and it can give really severe uh, issues. You can get a subluxation, and the brainstem could get compressed. I guess it's potentially fatal. Um, so um, oftentimes there seems to be a weight loss and fatigue that goes along with it. Uh, so so what we look for is a bunch of things. So it's got to be polyarthritic. That's the big thing. That's where I always start with it. It's got to be in more than three joints, or three or more. It's saying, but and bilateral at that. Um, Metacarpal phalangeal joints are, uh, and the proximal interphalangeal joints are the big ones. You don't see it so much in the distal interphalangeal joints. That when you see distal interphalangeal joints, think more OA. You don't normally get OA in the metacarpal phalangeals. Um, the morning stiffness, these people get stiff and it doesn't go away because it's not from gelling. So it lasts more than an hour. As OA is 10 minutes to a half an hour. So then generally what happens is people get blood work, and what they get is a positive for rheumatoid factor. Um, so that's usually the diagnostic criteria right there, because what they present with is morning stiffness and arthritis in three or more joints bilaterally, and then the doctor sends them for their blood test. It comes back positive for rheumatoid factor. The diagnosis is made then. Um, it could be just radiographic evidence too, like especially when you're getting kind of multiple dislocations. You get this. There's some characteristic looks to it. You don't really need even the radiographic. If you see this ulnar deviation of the four metacarpal phalangeal joints, it's almost invariably that. It's not enough to make the diagnosis, but it's uh, very indicative of it. Um, there's something else called swan neck deformity and boutonniere deformity, and that's the fingers kind of end up with this extension at the proximal interphalangeal joint with flexion at the distal interphalangeal joint, and or boutonnieres is the other way around. It's flexion at the proximal interphalangeal and extension at the distal. So it's basically both of them are, you can't hold the spine straight. Oftentimes nodules will appear under the skin, and it's a characteristic finding. Usually they're asymptomatic, but they can be there. Vasculitis will often occur, and sometimes what you'll end up with is these little like hemorrhage spots that are unique to it. They're especially on the fingers. So what do? You try and reduce the pain and limit the inflammation, because the inflammation is a big excuse me, a big problem, because this is a chronic inflammatory problem. You got to try and stop the damage. Uh, so they use nonsteroidal anti-inflammatories, but they also use prednisone and the steroidal anti-inflammatories. Uh, they do a lot um, of other things, like exercise, hydrotherapy, occupational therapy, helping people work with this disability. Teaching people how to hold things. There's an awful lot of devices like that will open jars and things for people who've lost the use of the metacarpal phalangeal joints. Um, there's a lot of drugs, and you will have patients. Methotrexate is the one that seems to be the common biological response modifiers right now. And so people will get on methotrexate, and it used to be that methotrexate was kind of later, but now they're using it earlier and earlier at diagnosis to try and slow down the advance of this. People, one of the reasons they end up taking prednisone as the anti-inflammatory is that it's also a very good immunosuppressor. And since the inflammation is caused by immune attack, an autoimmune attack, suppressing the immune system is not a bad idea. Um, but it has consequences. It has consequences that it can cause diabetes type reactions and osteoarthritis. Or, I'm sorry, osteoporosis. Uh, and the skin gets very thin. It erodes away at the dermis and the adventitia of the blood vessels, so people bruise and their skin gets like parchment, and they end up with osteoporosis and high blood sugars. So they, it's something that has to be kind of dealt with. Uh, Diet and exercise, stress reduction, all just seem to play a part in everything. One of the things that you don't want to do, and it's counterintuitive to a lot of people, is you don't want to strengthen the immune system. So things like echinacea are not a good idea for people with these autoimmune diseases, um, especially rheumatoid arthritis. Surgery is kind of a last thing, and they do it to stabilize or to deal with dislocations. It's not a curative joint replacement sort of thing, but more for ruptured tendons, ruptured ligaments, straightening things out. Sometimes they fuse. Like if you're going to have unusable metacarpal phalangeal joints, you might as well have them straight. So a certain amount of fusion has been known to happen. I don't think it's a very common thing, but nevertheless, it's in the realm of possibility. You got to be careful around these people because it's a systemic autoimmune disease. You don't want to actually increase circulation uh, when there's a flare up. When there's no flare up and there's not the attack going on, the immune system isn't currently attacking the synovium, then you work on muscle tension, increase range of motion, try and maintain joint health, traction, that kind of thing, and you're working for pain reduction basically at that point.